Oh, hey, Chris.
Hey Chuck, how are you?
I'm doing great. It's a beautiful day in St. Louis, recording a podcast. What could be better?
It is at the very least, I mean, we're doing it inside, but both of us have sunlight in the background, which is awesome. So that's a win. That's a win.
Yeah, it won't be the case at 5 p.m. when it's pitch black out, but we'll enjoy it while it lasts.
That's okay. I'll take that. I mean, so in the new neighborhood now, we go to the same church we went to before, but now we're able to walk to church. So that was our morning time outside time in the morning. And my son's got a soccer game coming up in about an hour and a half. So I'll be outside as well. It's a beautiful 60 degrees here in St. Louis and sunny, and it's amazing.
That is awesome. Although, if I'm remembering correctly, it's pretty much straight uphill to get to church. I imagine the walk home is a little more enjoyable.
Oh, it's not that long. I mean, so we have this mantra in our family that at your uh, at your urging, I read that book, that Clayton Christensen book, How You Measure Your Life, and he talks about mantras. So we developed a mantra about, I don't know, 2 years ago, or whatever, a year and a half ago. That's we are kind, patient, and respectful in our family. And the number of times that the kids have heard us say that, and I honestly have to remind myself that when I'm having a tough time at work, that I am kind, patient, and respectful as part of this family. But we were doing something yesterday, and Rafi didn't want to do something because it was hard, and my wife was like, we do hard things in this family. She's like, maybe we should add that to the mantra. So we are kind, patient, respectful, and we do hard things. Like, I don't know if we can change the sign that our nanny last year made us,
That is really funny. Bringing in a little
but it's,
Peloton.
I guess that's where it came from. It's got to have come from there. But yeah, so the walk uphill is not bad. It was a beautiful day. I actually was thinking on the way home, I was like, this might be kind of painful come February if there's ice and snow. I was like, maybe we'll drive then, but it really isn't very far, so it was nice.
I love it. I love it. Well, I'm glad you're settling into the new hood and hopefully you've met some neighbors and the like and all good.
Yeah. Halloween was great for that. They do it big here. I mean, I had never seen anything like it in terms of, everybody out with fire pits and, that whole deal, which was nice and welcoming. And, the kids really enjoyed Halloween. They obviously, our 3-year-old really took to running everywhere to get candy. She tired out after about 40 minutes. But, the first 30 minutes, she was sprinting to every door, just yelling, candy, candy, candy. It was cute, but
For a while.
we had to remind her about her manners a couple of times. But
That is great. I do have to say, and most listeners, this will not resonate, but I do love the St. Louis tradition where you just don't go get candy in St. Louis. You have to typically tell a joke, which is there's nothing better than 5-year-olds or 10-year-olds telling jokes and knock knocks. And I think it's a great tradition. I think it's great.
yeah, I had never seen that until coming here. So our daughter took our son's joke, and she got to the point where she was so excited, and we had to remind her about the joke thing. She'd run to the door while yelling candy. As soon as she got to the people, she would just blurt out the joke immediately without being prompted. No pause for the punchline, that kind of thing, and just hold out her bag. And I'm like, well, at least you told the joke.
Hey, that's part of the joy. Part of the joy. All right, what we got lined up for the show?
Well, we're going to talk about some articles from our recent Journal Club. So those of you that follow us on YouTube, we've noticed that the Journal Club sessions have gotten a lot of traction and have been very well reviewed. So we're going to bring that back and would love to hear some feedback from listeners, whether you think that's a useful thing. I mean, we won't make it strictly about the articles. We'll include kind of the context and how it may inform or not inform our practice. So hopefully you'll tell us if it's useful. Send us your feedback, handpodcast@gmail.com or at handpodcast on Twitter. And I wanted to read an email that was sent to us by Brittany Mitchell. She is a working towards her CHT, and she is a hand therapist in Salem, Virginia. And she gave us a bunch of questions and great feedback. And I wanted to just take a piece of what Brittany had told us or asked us. So here's one: steps taken for assessment and treatment of the arthritic patient. How do you know when to perform surgery versus conservative management? And do you prescribe therapy first, or does it depend on severity of arthritis? Now, Chuck, these questions are usually for you because you're the OG. You got all the wisdom. So why don't you take a stab at these?
Well, for better or worse, in my practice, much of this is patient driven. And I think most of the listeners can appreciate that that is different necessarily than the rest of the world, and patients do drive their care here, which of course in part they should, although I think it's our responsibility to guide them to, the concept of value-based care and really the best care. And certainly jumping to surgery is not typically what we do. The value of things like therapy, honestly, just simply hasn't been proven, especially for a diagnosis like arthritis. There are a couple of good manuscripts looking at the role of therapy in CMC arthritis with some pretty good results. And I do share that with patients, and I absolutely make that an option for patients, especially earlier in the arthritic process. Um, in my experience, once you go down the path of using steroid injections to modify symptoms from arthritis, at that point, therapy is typically less helpful, and then it becomes purely a patient-driven decision. It is almost never, and I can think of a few exceptions, but almost never do I push for surgery in situations for arthritis. And we've talked about this. I don't know if I captured well your thoughts on the topic, but that's where I stand.
Yeah, I think duration of symptoms and attempts at other treatment are what drive me towards surgery for a lot of my patients. I don't use radiographs as much, mainly because we see it routinely, that not only in the thumb, but also in the knee and the hip, for those of you that are orthopedics trained. The x-rays don't correlate with symptoms. I've seen awful x-rays in patients who aren't bothered at all, and I've seen pristine x-rays in patients who have terrible symptoms. So I don't use that to drive my management. One thing I do make a point of is eventually, if I do get x-rays, and I don't get x-rays initially on many of these patients, I usually get x-rays only if we're kind of heading towards surgery, mainly for surgical planning and also to show patients their x-rays. I think that's a very illustrative and helpful thing. I tell the trainees this, I try not to indicate surgery on the first visit. Now there are exceptions to that if somebody has, had treatment for a long time. For example, I see some of Dr. Gelberman's old patients now who have had lots of therapy and lots of injections, and they're ready. And then I also, I think I'm probably in a minority on this. I try not to put needles in people on the first visit. Because it's silly, but the needles hurt. And I don't want that to be their first impression of me. That being said, if they are in misery and in lots of pain, I will offer the injection. But usually we have the privilege of having therapists, colleagues in our clinics most of the time. So that's one entree into therapy. And sometimes they've seen the patient before me and kind of told me, yeah, they're ready for an injection, or they want to do some formal therapy.
Yeah, I like everything you said. And it's interesting. So earlier, and definitely more than 10 years ago, I was involved in a clinical practice guideline development process for the Academy on CMC arthritis. And you might think to yourself, gosh, Chuck, I missed that one. And that would be because it never was completed. I think likely because there was so little literature to guide us. But I remember sitting in this conference room, being on the younger side way back then, and listening to a couple of the older hand surgeons say, well, we don't even get x-rays. You don't need x-rays. It's a clinical diagnosis. X-rays don't help you in any way. And I'm thinking to myself, what? Of course you have to get x-rays. And now I'm like, x-rays don't help me at all. It is a clinical diagnosis. It is easily reproducible in almost every case. There are exceptions, but almost every case, the diagnosis, you can see the pathology, whether there's a contraction of the CMC joint or just pain. And it was an evolution. And I don't get x-rays along the way unless, like you said, I need them to talk to the patient, or sometimes when I'm considering surgery, I'll get x-rays, but it's not a priority.
It's interesting. There are some times where it's totally patient dependent. And even, we've gotten our Press Ganey patient satisfaction surveys back recently. And I admit I'm not perfect. And there are times where patients are unhappy. Usually the patients that are unhappy are the ones that are more vocal and have more apt to leave comments. And one of the comments I got was, he didn't even get x-rays. And I'm like, listen, I don't expect the patient to understand that that's not, that test is not going to change my management. But I feel like sometimes there is a therapeutic component, to getting an x-ray, in terms of having, not necessarily you going through the x-ray with them, but knowing that you cared enough to get an x-ray for them.
Yeah, it's really interesting. And clearly communication wasn't ideal. And I often find that sometimes I'll go ahead and suggest x-rays because you just see, the patient may not say it, but you just see that they want something more, and the x-rays can be that something more. And you're right. Sometimes it is just a almost necessity for the patient to leave your office satisfied that you did what you need to do. It's also the other mantra of they like to leave with something, leave with advice, or leave with a handout, or leave with a link. Of I think that really matters to some patients, but which patients is always the tricky part.
Let's just say in my practice or my clinic, we have a whiteboard in which I write kind of everything that I ask our team to do. The term X-ray OWO, meaning X-ray on the way out and not coming back, has become much more frequent than the last year because it's just easier, honestly, to send them for X-rays, to have them understand that we did it for them. I review it and I'll call them if there's any issues or anything like that. But again, you get the sense some people just want something to leave with.
Yeah, couldn't agree more. Couldn't agree more. That's a great conversation piece. The questions.
So yeah, Brittany, thank you for the fantastic email. We will get to more of your questions. And I know that you wanted to come to the ASHT meeting, but you couldn't. You're busy. You got two very young kids. We certainly will send you something in terms of swag because of your great questions and engagement. And thank you for listening. And again, if anybody has questions, please submit them through the email account and let us know. And then also sign up for the upcoming, it's been upcoming for a while, but the upcoming newsletter. And in this newsletter, we will also include links and details about the articles that we're going to talk about now.
Yeah, so we have 150 people signed up for the newsletter. Granted, we have about 1,200 and growing. It's really super satisfying that it continues to grow. About 1,200 regular listeners, but 150 of you have signed up for the newsletter. And hopefully that momentum grows. So we're close. It's on my list of things to get done. I hope it gets done this week. And I do think it'll make for an interesting forum for discussion. And we're never looking for one-way discussion, despite our choice of podcast format. So we look forward to feedback, of course, on this and other things that we do.
So Chuck, what does the number 2000 mean to you?
The number 2000.
In the year 2000. No Conan O'Brien fans? Okay, cool.
Yeah, that didn't help me. Tell me, what should it mean?
So we have over 2,000 downloads a week for the podcast. So thank you everybody for checking us out, telling your colleagues. It's something that we're very proud of. I had to update an educator portfolio recently. And I did it one time before promotion and had to do it one time since then. And it was very nice to change the number from over 1,300 downloads a week to over 2,000 downloads a week. So thank you, everybody.
Yeah, it's fantastic. Yeah, it means the world. And it's why you and I are sitting here on a Sunday afternoon talking to each other.
Well, let's jump in. So we probably should tackle the intimidating article first, that basic science article that amazes me, but also is very, in some ways, difficult to interpret. So this is from the group Yamanaka et al. And out of Japan, and this is in the October 6th edition of JBJS. So it's molecular and clinical elucidation of the mechanism of action of steroids in idiopathic carpal tunnel syndrome. That's a mouthful, but how do steroids work for carpal tunnel? So Chuck, before you read this, what was your thought of how steroids worked in those who you chose to give steroids to?
Yeah, I would completely buy into how I think steroids work everywhere as an anti-inflammatory, period, and kind of end of story. It's the explanation I give for the wrist when we're doing, what potentially with the TFCC tear, but it's absolutely how I conceived of steroids working for carpal tunnel syndrome. What about you? Was that your impression as well?
Yeah, my normal shtick is, when you have carpal tunnel, there's some swelling in the carpal tunnel. It presses on the median nerve, cuts off the blood supply to the median nerve because it's a confined space, and the nerve starts to get aggravated and irritated. And when it goes through this kind of dynamic ischemia, that's when you start to get the pain and paresthesias. And this is kind of on the earlier side of the condition. So yeah, I had the same impression that if you injected steroid in the carpal tunnel, you would cut the swelling presumably from the synovium surrounding the flexor tendons. And as you cut that swelling, the nerve would have, quote, more room to breathe. I didn't think it was swelling in the nerve itself though, but I thought it was swelling in that confined space.
Yeah, absolutely. And the authors here kind of really did two studies in one. And I don't know if this was related to feedback they got during the editorial process. I actually didn't think it was necessary. They kind of looked at outcomes with steroid injections in a group of patients, but that's not what you and I are focused on. We're really focused on the part where it's really interesting. They collected fibroblast from the subsynovial connective tissues during carpal tunnel release for patients with idiopathic carpal tunnel, and they incubated them with or without triamcinolone for 1, 3, or 7 days. And then they looked at expression of fibrosis-related genes and expression of inflammatory cytokines, which is just a super interesting thing to do. So kudos for thinking about an age-old question in a very 2021 kind of way.
Yeah, I think it's interesting. So for the listeners that, my simplistic understanding of the basic science of carpal tunnel syndrome is that initially you will have some inflammation. And as the process goes from this dynamic ischemia and becomes more of a sustained and prolonged compression of the median nerve, there will then be fibrosis within the nerve that can lead to some of the longer term findings that you see, the more advanced findings. Now, they were not studying the nerve itself, so they did not sample the nerve, but they studied the tissue immediately surrounding the nerve. So what they found was interesting enough is that when you incubated, the subsynovial tissue with the steroid, is that it wasn't really the inflammation that was cut. It was an effect on fibrosis related genes. So, this is super interesting and way beyond me in terms of the basic science. But I thought it was interesting that it was more about the steroid working on the fibrosis as opposed to the steroid working on the inflammatory components.
Yeah, I mean, I think your point of this is not the nerve, this is the surrounding tissues is important, but it's really dramatic findings that really change how I think about this. In the next paper, we're going to talk about clinical outcomes from steroid injection, which again, I think is better done than in what they did in this paper. But it's an important thing for us to process. It's important probably to share with the sophisticated patient, and really I think it's important for us to think about this as we move forward with additional investigations.
So for me, I mean, I don't know. It changes a little bit how I think about it, does not change what I do. Because we know that the steroid injections in that patient, in though a certain population will work. Now, the longevity is what we'll get into in the next article and whether it makes a true difference, but it will work temporarily. It doesn't change what I offer patients. I guess I've changed how I talk to patients about it. I kind of go back on whether it cuts inflammation around there. I think it may have some really interesting applications in the future. Say, for example, we did gene-based therapy for carpal tunnel syndrome. Now we know where to really target, but that is, far away from where we are right now and far away from what we do as hand surgeons, I think.
Yeah, and the other thing which resonates with me is another diagnosis, which would be tennis elbow, because we talk about tennis elbow as not being an inflammatory condition, and one of the justifications some use to avoiding steroid injections is just that. Um, and yet, this article shows that steroids can have an effect even beyond, or maybe instead of, their anti-inflammatory effect. And don't get me wrong, I'm not advocating steroid injections because while I do use them occasionally, there is pretty good science out there that they're not the be all and end all for tennis elbow, but it just makes me think about that diagnosis as well.
So let's get into the next article. So this is from Hoffer et al., and this was from Lund University in Sweden, and this is extended follow-up of local steroid injection for carpal tunnel syndrome and RCT. And this was in JAMA Network Open, and it was published, let me look at the publication date, October 22nd, 2021. Again, this will be in the show notes and then in the newsletter. So they did an RCT here, and this was amazing. 5-year follow-up after steroid injections. So they did a lower dose of 40 milligrams of methylprednisolone, and then double that dose in the second arm of the study, and then a placebo in the third arm.
Yeah, this is great, and this is actually this group of patients has been previously studied and reported on. So this is almost a follow-up study. But man, this is super well done. And really gets to the heart. It is interesting on perspective. It gets to the heart of why we think about injections. And just briefly to summarize, so they had more than 100 participants, and the bottom line is that steroid injections were effective in the sense that they decreased symptoms for a mean of about 6 months. And they slightly, but not dramatically in my mind, decreased the number of patients that went on to carpal tunnel. So as a surgeon looking at these data, essentially it confirmed what I already thought. Steroid injections buy you time, but do not fundamentally change the benefits of surgery. And most patients come to surgery, and often it's not very long from now. However, the way the article reads is kind of like, well, steroids are great. They're a great option for patients to consider. It's just not the way I think about it.
Yeah, I think it's really interesting. So in the let's look at the actual results here. In the placebo group, the percentage of patients that went on to have surgery was 97% within 5 years of the injection. In the low dose steroid injection group, the percentage that went on to surgery was 92%. And then in the high dose, it was 84%. So 84% of people still went on to have surgery. Now that is significantly lower than the 97% in the placebo. But again, 84% went on to have surgery. But the way that the conclusions and relevance section of the abstract reads, you would think that an insurance company, potentially, who may not read the entire article, somebody from an insurance company, may say, you know what, why are we paying for surgery in all these patients?
Yeah, and that would be a huge error. And the other, I think, of all this is interesting and helpful. To me, the most important take-home message is the time to surgery, which is pretty consistent at 180 days. So this says, look, on average, you can expect 6 months of going down your current course, but then on average, that's when you will consider surgery to be the right approach for you, which is pretty disappointing, because that means that if it was 6 months until surgery, presumably they're thinking about surgery as early as 3 months after an injection. And so to me, this means that injections, again, don't really have a strong role in my practice unless there's a specific patient-driven thought process around delaying an intervention.
Yeah, so in the placebo group, they had the mean time to surgery was 4 months. So, like you're saying, I think my take home on this is that it works, buys you time, probably gets you about 6 months. And I think that, this kind of segues us into the next article, the article from Kazmers in the group out in Utah, that looks at, complications potentially of whether you did this surgery. This is an example of a trigger finger release, but probably very similar findings for a carpal tunnel release. So, for me, the advent of local only surgery without a tourniquet has changed, I think, my threshold to indicate surgery, both on a medical basis as well as on a hand surgery basis.
Yeah, totally agree. Shoot, actually, I don't agree because I didn't hear what you said because I was typing. I'll cut this out. Tell me what did you say?
I said that my threshold to offer surgery has changed, both from a medical perspective and from a hand surgery perspective, based on the advent of Walon.
So, Chris, I could not agree more. It's just so simple, and I don't want to be naive and come across as unaware of risks, even in a local only type procedure. But the local only procedures really are so much less demanding on the patient. They're so much less demanding on the system, and they're just easier in every way and less expensive and greener, in the sense that we're saving the world from all the rigmarole that goes into a OR based procedure. This study is timely and really is impactful. It took the simple example of triggers, but really it can be extrapolated, as you mentioned, to certainly carpal tunnel, if not further.
So this is from our WashU residency alum, Nick Kazmers, who has been doing amazing things with the group at University of Utah. And so this was published in JHS, and the data publication, let me pull this up here. I don't know if, yes, so this was in the October issue of JHS. So the article title is Comparison of Complication Risks Following Trigger Finger Release Performed in the Office versus the OR, Population-Based Assessment. And they actually worked with our administrative data group here at WashU, who I've worked with a lot. So methodologically, I think among the most rigorous of all of these groups who use administrative data. So I immediately knew that it was a well-done study. I actually remember connecting Nick with Margie Olson to do this study, and then forgetting all about it, and then reading the study and saying, oh, so they finally did it. So they use MarketScan, which is a commercial insurance database. So no Medicare and no Medicaid, but just commercial insurance in the US. And they looked at almost 38,000 cases, 7,600 which were done in a procedure room and 30,000 that were done in the OR. And they looked at the risk of medical complications, which was significantly lower in the procedure room setting. And they also looked at surgical site complications, which was not significantly different, although just those of you that want to know the absolute percentages, it was 0.67% in the procedure room cases and 0.88% in the OR cases. And there were very few iatrogenic complications, less than 0.07% in the, 0.07% in procedure room and 0.09% in the OR. So, this was really interesting. To me, it showed that procedure room cases can be done quite safely from both a medical perspective, as you would expect, and from a surgical perspective.
Yeah, it is timely in the sense that there is a group of us, and I will put myself in that group in the past, but I think I'm a convert. But there's a group who says, look, I don't know about the infection risk, and I don't know about complications, and I don't know about lighting, and I don't know about can my group handle it. The reality is, local only surgery is a win. And yes, it absolutely requires system-based thinking. It requires coming together on processes and doing things differently. And let's be honest, you and I are still on that path to figuring out how to do this efficiently, safely, and effectively. But this is the future. It's right in every domain. So why aren't we doing more of it?
One would argue that it's not the future and perhaps we are behind, because clearly, this is happening in a substantial number of trigger finger cases. So, 7,600 out of 38,000 cases, that are going on. So, we should be doing this more. One thing, this is a fantastic article. One thing I wish that Nick and the group had compared were the procedure room cases with the local only in the OR cases. Because I thought that would be an interesting comparison, and I'm sure there were reasons why they didn't do it. But I think that would give me a better sense of the complication risk, more apples to apples.
I think that's a great point. It is a nice segue. It's a nice intermediate step to go from traditional hand surgery to local only in the OR to local only in the clinic. And I think you and I are sort of on that spectrum of more the middle group and growing local only group.
Yeah, we've talked about it on the pod in the past, but when we had our second wave of OR closures back in December of 2020, when they closed our ambulatory centers, I did, I think, 20 cases in the office, triggers and carpal tunnels and the Quer veins. And we informally administered a survey, and now we're waiting for it's in peer review at a QI journal. But the patients overall were incredibly happy, and knock on wood, I think I'm out of the window of complications from those cases, at least the ones that you worry about the most. And patients did really well. Now, again, like you said, it took a lot of work to make that happen, but I think that's the way that we're going to end up going.
Yeah, you're right. It is the future, but it is now, and you and I have to catch up with.
Chuck, it's not the future. We're just behind.
All right. Well, I loved all three of these articles. I think they're all impactful and will be cited in years to come. So it was fun reviewing them with you.
Yeah, absolutely. So it is, I have to put on my fellowship director hat and say that, this is the kind of stuff that you're going to get if you were to check out our fellowship program. Applications are out right now. Marty and I actually did our first Ask Me Anything session yesterday. It was incredibly well attended for being this far away from interviews. So we had 15 people on, including some PGY3s and that aren't even applying yet, which was really cool to see. So we're really thankful for everybody that participated. I'm sure some of you also listened to the pod as well. And my son made a guest appearance and insisted that I use a Zoom background that was a tiger, which was a little bit weird when he actually stepped away and I had this Tiger King thing in the background. But anyway.
Yeah, a little weird.
Well, everybody, enjoy the rest of your day. And Chuck, thanks for chatting about these articles. And we look forward to the next pod.
Absolutely. Have a great day.
You too.